more than 20 years as an HIV physician at Chelsea and Westminster Hospital in London. And during my work, and I still continue to do a clinic there, and it's a clinic specifically for women living with HIV who are in the menopause. But I also have an interest in HIV pre-exposure prophylaxis, particularly for women, and how to, I guess, help women access PrEP, because unfortunately this is something that is not widely available for women, and many women don't know about it. But my particular interest is in the sexual and reproductive health of women living with HIV. And so today I'm going to just talk to you about some of the issues that I think are relevant to women living with HIV, but I would very much like your input into this talk. I don't want it to just be me. I would really like you to contribute and to share your thoughts on what I say, and your thoughts on some of the issues that trouble you, or that actually are good for you, because I think that it's important for us also at VIV to understand the issues that women go through, but also it's important for me as a physician, as a continuing practicing physician, to really understand the concerns of people living with HIV, and as I said, for me particularly the concerns of women. So I am not very good with technology, but I will now try to share my screen. Let's see what happens. Okay, it looks like. So I hope can you all see? Because I can't see you anymore because the screen is there. If somebody could just come off mute and tell me if you can see the screen, please.
Yes, we can see the screen.
Okay, great. Thank you very much. So as I said, I have introduced myself to you, and the title of my talk is HIV in Women, Lessons Learned Along the Journey. And as I said, I'm a full-time employee of VIV Healthcare. And in my talk tonight, I'm going to cover these areas. I'm going to talk a little bit about HIV, or the prevalence of HIV. So I guess the proportion of women living with HIV in the world. I'm going to talk about some of the issues that relate to women living with HIV, particularly with regard to the different ages or stages of the lives of women. I'm going to mention a little bit about pregnancy and breastfeeding, and this is an area that I would really value your input, because I think it's really important that we as healthcare providers understand the issues that women face with regard to pregnancy and breastfeeding. I'm going to talk a bit about hormones and HIV, so contraceptive hormones and also menopause hormone therapy. And then I'm going to talk about some of the considerations for antiretroviral therapy in women. I'm not talking about drugs, and so I won't be speaking about particular treatments, but just about treatment in general. And so I would prefer that you not ask me questions about specific medications that you might be taking or that friends of yours might be taking, because I'm not going to be able to answer those questions, I'm afraid. And then I will just briefly summarize. So, first of all, epidemiology. So you may be aware of the fact that actually the majority of people living with HIV in the world are women. So 52% of people living with HIV in the world are women. And the majority of them, as you know, live in sub-Saharan Africa. So this relates to the majority of women of reproductive age. So, sorry, young women, adolescents and young women. So between the ages of 18 and 24. But it's also important to remember that across the world, women make up a substantial proportion of people living with HIV. So even though the majority live in sub-Saharan Africa, actually across Europe, about 30% of people living with HIV are women, even in countries where the majority of people are men who have, the majority of people living with HIV are men who have sex with men. So women form a very big proportion, a substantial proportion of people living with HIV worldwide. But it's very important also to remember that there are many transgender women across the world, and HIV prevalence, so the number of transgender women living with HIV, is also very high. And the particular concern with transgender women is that actually the majority of transgender women do not know that they are living with HIV. And so because of that, they are unable to access treatment. And so they come to healthcare services late and often are very ill when they come to healthcare services. But also because they are not on treatment, they can transmit HIV to other people. This is a slide that comes from the Public Health Department in the United Kingdom, Public Health England, and it shows how the number of women accessing HIV care by age is changing. So it's now a quite old slide, but I think that it illustrates what is going on now, and that is that in 2017, and also I know this is the case from 2018, 1/3 of women accessing HIV care were of menopausal age, so between the ages of 45 and 56. And in the UK, there are about 103,000 people living with HIV. So that means that there are 10,000 women of menopausal age. And Public Health England estimates that in the next 10 years, there will be a further 10,000 women of that age. And so it's important to remember this. And, you know, we are all getting older. And so women living with HIV are also getting older, particularly because now with modern treatments, we expect that people living with HIV will have a normal life expectancy. So 20 or 30 years ago, women were not really achieving menopause because they died of HIV-related conditions before they reached the age of menopause. But now, because this is not happening so much anymore, many women are entering and going beyond menopause. And we now have many women living into old age with HIV. And so it's very important that we understand this and that we identify these women so that we can treat them appropriately. We know, for example, that women who have severe menopause symptoms may be less likely to take their treatment properly. They may be less likely to be adherent to treatment. And so it's important, first of all, to identify women who have symptoms and try to manage them, but also try to look at ways to encourage adherence. And so what about living with HIV? So the concerns or the considerations that we think about with regards to women living with HIV relate to their age and whether they are of childbearing potential, for example, or whether they are older and into the menopause and beyond. And we know from many studies that actually women do struggle with tolerating their antiretroviral regimens. They very often have more side effects than men. And this was certainly the case with the older antiretrovirals that we used to use, but actually more recent studies have also demonstrated that even with the antiretrovirals that we are using now that tend to have fewer side effects than the old ones, women do tend to struggle with side effects more than men. And this is the case both with younger women as well as with older women. We know also that women face barriers to accessing treatment in some populations. So even where HIV treatment services exist, and even in situations where women live or work close to those HIV treatment services, women face barriers to access those those services. And that is sometimes related to the fact that they are too busy looking after their families or working, or that they face barriers because their partners do not allow them to attend and they are financially unable to get to those places by themselves because they depend on their partners for money. There are many barriers that we know that women experience that stop them from attending services. And this is not just HIV services, this relates to all sorts of healthcare services. We know that some antiretrovirals are now associated with weight gain, and I won't, as I say, go into details about individual antiretrovirals, but weight gain is beginning to be something that we are thinking about and that we are noticing in certain groups of people, and that is a concern for women, particularly as they get older, because one of the things that happens with the menopause is that, or actually with getting older in general, and not just with the menopause, so with men and women, is that people gain weight as they get older. And so if any of their treatments are contributing to this, it may become a problem. For younger women, we know that there's an issue about what contraceptives they might use if they have a partner who is HIV negative. But actually, we are now in a situation where, thankfully, people who are on effective treatment with an undetectable viral load cannot transmit HIV to sexual partners. So the issue of transmission to an HIV negative partner is no longer a concern. And so one doesn't, in addition to taking contraception to prevent pregnancy, have to then also use condoms unless one is worried about STDs, because obviously being on treatment does not prevent STDs, even though it prevents HIV transmission. There are worries about drug interactions with hormonal contraception, because some antiretrovirals may interfere with the way that hormonal contraception works and make the contraception less effective. So this is something that women have to think about. And then again, for younger women, there are concerns about conception, about getting pregnant. In the early days of HIV, when people had very suppressed immune systems, it was found that actually women living with HIV often found it difficult to get pregnant. This is not so much the case now, and it's not so difficult to become pregnant with effective treatment when the immune system is functioning properly. But even when women do become pregnant, they worry about transmitting HIV to their babies, and this is something that I will talk about a little bit later in the talk. And then again, there is this issue that I mentioned earlier about the safety of both the mother and the baby during pregnancy and breastfeeding. So it's important that treatments that the mother takes do not harm her, but also do not harm her baby, either during pregnancy or during breastfeeding, but also that treatments that the mother takes she can tolerate, because often women feel very unwell in pregnancy. So if you are taking a medicine that makes you feel sick and makes you want to vomit, then that is not an ideal situation. For older women, many of the issues that I discussed for younger women are also relevant, but as I mentioned earlier, there are fairly good data now to show that women who, as they get older, and particularly in the menopause, if they have significant symptoms in the menopause, find it difficult to adhere to their treatment. And that means that there is a risk that their treatments may fail and that they may develop resistance. So this is really an important thing to think about. Also, we know that as people get older, they start to suffer more what are called comorbidities, so other illnesses that are related to age. So things like osteoporosis happens as people get older, heart disease, for example, kidney disease, liver disease. All of these things become more common as people get older, and often they need treatment themselves. And so people living with HIV have their antiretrovirals to take, but then they also need to start taking treatments for the medical conditions that they start to experience as they get older. And the same drug interactions that I mentioned for contraception also are relevant for hormone replacement therapy. So for women who choose to take hormone replacement therapy, it's important that they are not taking antiretrovirals that will interfere with their hormone replacement therapy. And again, I will talk a little bit more about this later. And I've talked already about the increased symptoms that women may have in the menopause. And there is some data to suggest that women living with HIV may experience more severe menopause symptoms than women who do not have HIV. Some studies show this and other studies do not, but there does seem to be some data that this is the case. And so what about pregnancy and breastfeeding? So what sorts of things need to be considered for a woman who is pregnant or who is wanting to become pregnant? So when we think about antiretrovirals in pregnancy, some of you may remember that there was a time when we didn't routinely give women antiretroviral therapy in pregnancy for their own benefit. When, you know, there was a time some years ago when people were offered antiretroviral therapy or were started on antiretroviral therapy based on their CD4 count. So if a woman was pregnant and had a high CD4 count and the guidelines said that she didn't need antiretroviral therapy, then that woman would be started on treatment to prevent transmission of HIV to her baby. But then after her baby was born, very often her antiretroviral therapy would be stopped. But actually, we are now in a situation where everybody living with HIV is recommended to be on treatment, including pregnant women, and to stay on treatment after the baby is born. And this is important for the health of the mother and the well-being of the mother. So it's important that the mother is healthy during pregnancy and remains healthy after her baby is born, and important for the delivery of a baby who does not have HIV. And the aim of treatment is to achieve suppression of the viral load as quickly as possible and to keep the viral load suppressed so that there is no risk at all of transmission to the baby. And so it's important to think about regimens that are tolerable so that women do not have side effects from, and that are safe, both for the mother and the baby, as I have also said. But what's also important, I think, and I'll be very interested in your comments at the end of this talk, is about the fact that we know that although many women living with HIV come to clinic regularly and are retained in care during their pregnancy, because the one thing that they absolutely want is to deliver an HIV negative baby, that very often after the baby is born, many women are lost to follow up. And there are many reasons for that, which are mainly related to how difficult it is to look after a small baby and to look after your health. And women in many situations, not just women living with HIV, really struggle to look after themselves when they have a young baby. And so this is a time when women very often stop coming to clinic, and so stop taking their treatment, for example, because they can't get back to refill their prescriptions, and so are at risk of becoming very unwell. And one of the things that I'll talk about later is that may then have become a problem with regard to breastfeeding. And I'm going to talk to you a little bit about what data exist on breastfeeding in women living with HIV. And so this is a cartoon that my 13-year-old niece drew for me. She's a very good artist, and I said to her, can you please draw me a picture of a pregnant lady and a doctor? And this is what she drew. And I'm hoping that she does not think that this is what I look like. Maybe she does. So the reason that I'm showing this slide is because I don't know if you realize this, but very few of the antiretrovirals that exist at the moment that we give to our patients have actually been tested in pregnancy. And the reason for this is because, which is completely understandable, is because there is a fear that treatments may harm the unborn baby. And that is definitely a justified fear. But what it means is that we end up giving medicines to women who are pregnant that we do not know whether they're safe or not. And what happens very often in studies, so when we're doing studies of antiretrovirals to see whether they're safe or not, is that first of all, we exclude pregnant women. So we say when we're listing the criteria to allow somebody to participate in a study, women who are pregnant cannot be included. And we also say women who are of childbearing age must use very effective contraception. And sometimes that contraception is much more than a woman would be required to use in normal life. And if women do then go on to become pregnant, they're excluded from the study. And what that means is that we then do not know what the outcome of that pregnancy was, because nobody will then go on to continue to collect the data. So we don't know whether women who started an antiretroviral therapy and then became pregnant went on to develop, their babies went on to develop problems. And we then continue to prescribe these same antiretroviral regimens without any data about whether they're safe. And so one of the things that we are doing, and one of the things that I am that I feel very strongly about, is about looking at ways to include women in clinical trials who are pregnant in the safest possible way, so that we can get proper data that say, yes, this drug is safe in pregnancy, or no, this drug is not safe, because otherwise we're exposing women to medicines that are completely untested. And so that is the basis for this slide. I want to say a little bit about HIV testing in pregnancy, and I'm sure that you're all aware that national and international guidelines recommend HIV testing in pregnancy, and the majority of women in most countries will be tested, usually in early pregnancy. But often that is the only time that they are tested, just when they make their first antenatal booking infection. And this slide shows you how the risk of HIV infection during pregnancy and after pregnancy increases, in fact. So the risk of this is a situation where a 25-year-old non-pregnant woman has a partner who has a viral load of 10,000 copies per mil, and so if they were to have sex 1,000 times, the risk of the woman, if she was not pregnant, would be basically 1, so not very high. Well, so high, but not terribly high, and that's related to the fact that the partner's viral load is not very high, for example. But in early pregnancy, she's twice as likely to to catch HIV than when she was not pregnant, and in late pregnancy, so in the third trimester, she's nearly 3 times as likely to catch HIV, and in the postpartum period, so that is in the 6 weeks after delivery, look how high the risk goes up to 4 times higher. And the reason I'm showing this slide is because if a woman has a partner who is living with HIV, or who knows or does not know their HIV status, and they're tested at the beginning of their pregnancy, but they continue to have sex with that partner throughout their pregnancy and after the baby is born, the risk of the woman catching HIV continues to increase, and the majority of women are never tested again after their first test. And so the reason for showing this slide, and I show this slide often to healthcare providers, is to emphasize the importance of speaking to women about their circumstances and assessing their risk of catching HIV, and offering further HIV testing if there is a need. But I also would suggest to you, talking to friends and families and friends and relatives who are women, that if they think that there is a chance that they might be in a partnership with somebody living with HIV and they're pregnant, that they also ask for an HIV test over the course of their pregnancy, just to be absolutely certain that they that they do not catch HIV. And this is important because if a woman catches HIV during pregnancy, the risk of transmission to her baby is really, really high. And that's because the viral load when you first catch HIV is extremely high. And so this poses among the highest risks of transmission to a baby if a woman catches HIV during pregnancy. And now I want to speak a little bit about breastfeeding. And so you will all be aware of the fact that in general, women from a very young age are told that breastfeeding is best for their babies. Everyone knows this. Girls grow up hearing this every day. And then when women are diagnosed with HIV and become pregnant, they're told not to breastfeed. And they're just told, don't breastfeed, just like that, with no conversation, no attempt, I think, by many healthcare providers to understand what this means for somebody who has been told her whole life that the best thing that she can do for her baby is to breastfeed, and then suddenly in one sentence she's told that she cannot do that. And when you think about the context of many women living with HIV in parts of the world that are not in Europe, for example, remember I showed you that 80% of women living with HIV live in sub-Saharan Africa. Many of these women do not have access to safe drinking water and may not have money to afford formula. So they have the difficulty of needing to feed their babies, and so breastfeeding their baby with the risk of the baby catching HIV from breastfeeding, or formula feeding their baby in an environment where they don't have safe water, so the baby being at risk of catching gut infections and dying of diarrheal disease. And that is a horrible choice for women. And there are many guidelines, and there have been many guidelines about how women living with HIV in countries where they can't have safe access to drinking water should breastfeed, so breastfeeding for 6 months exclusively and so on. But actually in recent years, because antiretroviral therapy is now so widely available in many parts of sub-Saharan Africa, for example, many women are able to breastfeed in those countries as long as they have an undetectable viral load. And so what we have now is a situation where the female relatives of women living with HIV, so of women in Africa who live in the Western world, will be told you should not breastfeed, because we know that in the UK, in Norway, in America, people can get formula easily. But you may have a relative in Malawi, and the female relative in Malawi says, I'm breastfeeding, I'm on antiretroviral therapy, and I have had 2 babies who are HIV negative. And so the lady who lives in Oslo, for example, will be saying, oh, well, but my doctors say I can't breastfeed. And then that causes a difficulty for her, because first of all, because it's something that she wants to do, but secondly, because it's something that is culturally very, very important for many women. And I again would be very interested to hear your views on what I'm about to say. But certainly in my experience with some of my female patients, what I've experienced, what they've told me, is that very often their mother-in-law will come to stay with them when they have a baby, when she has a baby. And if she's breastfeeding, then she has to go upstairs and hide, because the mother-in-law will not understand why she's breastfeeding, because not breastfeeding is effectively a declaration of HIV status. And I certainly have had women patients who have gone upstairs to breastfeed, and then the mother-in-law opens the door without a knocking, and then she sees her daughter-in-law breastfeeding. And that basically just tells the mother-in-law that her daughter-in-law is positive, and she may not have known this. And this has caused great problems in families. And so I think it's very important that healthcare providers are aware of this difficulty that women living with HIV who live in the West experience. So, and the data from breastfeeding comes from a study called the PROMISE study, which is a study in sub-Saharan Africa mainly, which looked at breastfeeding in women who were on antiretroviral therapy. And actually, when you think about the risk of mother-to-child transmission during pregnancy, which is less than 1 to 2%, so it's not zero, but it is very low with effective antiretroviral therapy. The risk during breastfeeding, if a woman is not on treatment, is very high. But this study from sub-Saharan Africa showed actually a rate of 0.3% at 6 months and 0.6% at 12 months. So that is a very low risk of transmission. It is not zero, so there remains the possibility of a risk of transmission, but it's a very low risk of transmission, and it's certainly something that should be discussed with women about whether or not they feel that this is a risk that they can potentially take. And so I've explained, I think, why I think this is important. And so what do the guidelines say about breastfeeding? So these are the guidelines from the European AIDS Clinical Society from last year. And the EACTS guidelines, but also international guidelines, definitely talk about the benefits of breastfeeding. And they acknowledge that in many circumstances, the benefits of breastfeeding outweigh the risks. The psychological benefits for the mother, the health benefits for the baby, in fact, health benefits for the mother. And so there does have to be a sort of risk-benefit balance about breastfeeding. And until we had this data about viral loads, actually, the risks of breastfeeding were greater than the benefits, because we didn't know whether breastfeeding reduced the risk, whether being on antiretroviral therapy reduced the risk of transmission. And the guidelines say basically that the topic of breastfeeding should be discussed as early as possible in pregnancy, with provision of education and support, so that women are able to make a decision that they are happy with. And that decision may be that they do not want to breastfeed, but it could also be that they do want to breastfeed. And although the guidance advises against breastfeeding, so none of the guidelines say we recommend that you breastfeed. They all say we recommend that you don't breastfeed. But what they do say is that if a woman, knowing all the risks and the benefits, chooses to breastfeed, that there should be input from a multidisciplinary team to support her to do that. And supporting her to do that means, and this is, I think I have got this on, supporting a woman to do that basically means being absolutely certain that she understands the importance of adherence. And this is one time, as is the case during pregnancy, that adherence is crucial, that she must not miss any doses of her antiretroviral therapy, that it's really important that she maintains an undetectable viral load. And that may mean doing more frequent viral load testing to check that it remains undetectable. But when I first started doing HIV, women who breastfed had their children taken away from them because they were deemed to be putting their children at risk. And this is no longer the case, certainly in the United Kingdom, that women should be criminalized for doing something that comes naturally to women, because women do not, when a woman breastfeeds, she's not doing it to harm her child. She's doing it because she thinks it's the best thing for her child, or because she has circumstances that prevent her from bottle feeding. And so the guidance now supports the idea that if a woman does decide to breastfeed, and as long as she knows what the potential risks are, that she should be supported to do so. But I would, as I say, when we come to the end of this talk, be very, very interested to hear your views about this. Coming towards the end of the talk now, I'm just going to mention a little bit about hormones and HIV. And we know that with the older antiretrovirals, women had very limited contraceptive options because of drug-drug interactions with the hormones in many forms of contraception. And so, until fairly recently, women could only have used condoms, or either male or female, or have a coil, either a hormone coil or a copper coil, or have the contraceptive injection. But now I just want to point out the fact that we now have many, many antiretrovirals that do not interact with hormones. And this also includes gender-affirming hormones, hormones for transgender women. And so, in fact, to me, it's really important that when a discussion about antiretroviral therapy is being had between a woman and her healthcare provider, there should be a discussion about what contraception she is using or that she wants to use, and that her HIV regimen should be tailored to enable her to use the contraception that she wants to. Because we know very clearly that women who do not have access to the type of contraception that they want, or who are given contraception that they don't like, do not take this contraception, and so have unwanted pregnancies. So it's really important that we take into account women's plans for contraception when we're thinking about antiretroviral regimens to start them on. And now a bit about HIV and older women. So I really like this slide from The Telegraph, which is a newspaper in the UK. And it basically shows that a child born in 2015 is likely to live to be 100 by the year 2055. So this is a slide from 2015. And this really shows that the life expectancy for people in the general population is going up, as is the case for women living with HIV, or for people living with HIV. And you may not be aware of this, but 40% of a woman's life is spent in the menopause. That doesn't mean that she will have menopause symptoms for 40% of her life, but if she lives to be 100, then 40 years of that life will be menopausal. And so why is this important? It's important because menopause may be associated with health problems. So many of which are problems that are just related to getting older in general, but most of which are related to the fact that at the time of menopause, women stop producing the hormone estrogen, which is basically the hormone that makes women women, enables them to get pregnant, is responsible for developing the characteristics that make a woman, so breasts, for example. And when the menopause starts, the levels of estrogen, this hormone, go down. And as those levels go down, some women start to suffer significant symptoms. So the typical symptoms that we are aware of, hot flushes, sweats, often their brains don't function so well. Many women complain of that. But also, as I said, menopause is associated with the development of many of the diseases that occur with aging. So heart disease, kidney disease, osteoporosis or weaker bones. And so with that, the risk of fractures, and fractures or breaking your bones in old age is often a significant cause of hospitalization, but also a significant cause of death. Cholesterol goes up very often. There's an increased risk of type 2 diabetes and high blood pressure. And also an increased risk of something that you may have heard of, which is called the metabolic syndrome, which increases the risk of heart disease and of dementia and of certain kinds of cancer and depression, but also an increased risk of sexual dysfunction. And we know that sexual dysfunction is very common in women living with HIV, regardless of age, but the menopause also itself brings with it poor sexual function. And so living with HIV and menopause may in fact result in extremely poor sexual function of women living with HIV. So what do we know about the menopause and HIV? So I was mentioning, well, I haven't mentioned actually, but I will now. So we know that people living with HIV report a very poor quality of life in general, particularly with regard to symptoms like pain, but also symptoms such as anxiety and depression. And you can see from this slide that there is a significantly more anxiety and depression in people living with HIV compared to people in the general population, so 50% compared to 24%. And then when women reach the menopause, they have this to contend with. And so I know that this slide is a funny slide, but some of you who are experiencing severe symptoms of the menopause actually may not be laughing at this slide, because for many women, this is a really terrible time. And unfortunately, the menopause is something that women do not speak about. And it's something that we really, that is very difficult to understand. All women go through the menopause, but I don't know of anybody's mother who talks to them about the menopause, or anybody's sister. And women have been going through the menopause for thousands of years. But what we have seen in the UK, and I'll be interested to know whether this is the case in Norway, is that because some very prominent women, celebrity women, are now going through the menopause, actually they are talking about their experiences, and so this is now being talked about in public. And many organizations such as workplaces and so on are now taking into account employees who are menopausal, and trying to make adjustments within the workplace to make sure that women who are of menopausal age are able to continue to work successfully. Because one reason for women retiring from their jobs early is suffering severe menopausal symptoms. So is menopause different in women living with HIV compared to women in the general population? Well, there is some data that suggests that it may be. Most of the data comes from the United States, and we're starting to collect data from the UK, and there is also some data from Europe that is looking at this. The results are very mixed. Some studies suggest that there is not much difference, but there are other studies that suggest that there is a difference. But what we do see is that women living with HIV, as I said before, appear to experience more severe menopause symptoms, and there is some evidence that they may also experience menopause earlier. One thing that happens with the diagnosis of menopause in women living with HIV is that the diagnosis is very often delayed, because many of the symptoms are very similar to the symptoms that women suffered at the time of their HIV diagnosis. So sweats, aches and pains, feeling hot. And so many women think that their HIV, which was previously well controlled, is no longer controlled. And they go to their HIV doctor and say, I think my viral load must be detectable because I'm feeling the way I felt before I started treatment. And the HIV doctor checks the viral load and says, no, your HIV is completely well controlled. It's not your HIV. And they go back to their general practitioner or their family doctor, and they say, I feel really terrible. And my HIV doctor says, it's not my HIV. And the GP says, no, it must be your HIV because there's nothing wrong with you. I don't know what's wrong with you. And nobody has thought that this woman might be menopausal. And so women will very often, sometimes for years, go back and forth between their GP and their HIV physician with symptoms, and nobody has thought that actually this could be menopause. And often the women themselves don't realize that it's menopause because they may start to have symptoms while they are still having regular periods. And so if you're having regular periods, your first thought is, well, it can't be menopause because I'm having regular periods. But menopause symptoms can actually start before the periods start to change. And we know that the use of hormone replacement therapy in the general population is fairly low because of many scares about hormone therapy over the years, but it's even lower in women living with HIV. And so they don't then get the relief that they could have that could help their symptoms. So actually, so in fact, the previous slide in which I talked about considerations for antiretroviral therapy actually just relates mainly to what I said about using antiretrovirals in a way that enables women to use to take the hormone treatments that they need, but also that enables them to take the treatments for comorbidities, for the increased diseases of aging that they may start to need. So avoiding drug-drug interactions between antiretroviral therapy and the other treatments that people need. And the other point that I want to emphasize, which is a point that I made earlier in this talk, is about the fact that as well as many antiretrovirals not being studied in pregnancy, actually women are very underrepresented in clinical trials. So I showed you the first slide that showed that 52% of people living with HIV are women. But in fact, only 19% of people who participate in clinical trials are women. And so what that means is that we end up using data that mainly comes from men and applying it to women. And we know that there are many differences in the makeup, in the biology, in the physiology of women compared to men. That means that some of the conclusions that we make from these clinical trials may not be rightly applied to women. And so it's really important that we enroll women in clinical trials so that the data that we get can be applied to them. And so there is a responsibility for us, as a company, to recruit women into the trials that we do. There is a responsibility for physicians to talk to women about participating in clinical trials and to help them to understand the importance of participating in clinical trials, but also to you as women to ask about clinical trials when you are going to your clinics, to say, are there any studies that I might be able to participate in? And I know that many people have worries about clinical trials, but it's important that you raise your fears about participating in clinical trials so that people can explain to you what it means to be in a trial, because often people are frightened to participate in clinical trials because they've heard bad things or they've heard things that are wrong about clinical trials. So being given the opportunity to hear the right information about clinical trials and then to make up your mind about whether this is something that you want to do is really important. And this is not to force people who don't want to be in clinical trials to be in them. It's everybody's right not to participate in clinical trials, but there are many people who actually want to be in clinical trials. And we've done surveys where we've asked women if they want to be in studies, and they say yes, but then they're not asked to participate. And that is mainly because people are worried about pregnancy, which is what I talked to you about before. And so in summary, this is just to say that women make up a substantial proportion of people living with HIV worldwide, that women should be active participants in their healthcare, with information provided to them in ways that respect their autonomy and enable them to make informed choices. It is not our place to tell women what to do without explaining why we think it's important that they do these things. Women should be able to make up their own minds about what they want for themselves and what they want for their health. And despite the fact that there are very few women included in clinical trials. I believe that healthcare professionals should aim to tailor antiretroviral regimens to the specific needs of individual women, and try to avoid drug-drug interactions with hormonal and other therapies. And care for women living with HIV should proactively include discussions about reproductive health, including contraception, pregnancy, and the menopause. And we should strive to ensure that women have access to the same level of care in reproductive services as HIV-negative women. And with that, I would like to say thank you very much. And I will come out. Oh, what have I done? Okay. Oh, yes. So.
Yeah, thank you so much, Neneka. But you have some, it was a very interesting presentation. So we are so happy that you could share this with us. We have some comments and also a few questions. You asked about the situation and our thoughts here in Norway, and breastfeeding is not recommended for women living with HIV in Norway, but they are trying out a project now with a few who want to breastfeed. And the penal code has also been changed so that you can no longer be prosecuted. But we experience that especially women with a migrant background struggle with the fact that they cannot breastfeed because the extended family expect this, and many have not told about their diagnosis. And we were also, is it your recommendation that the women who choose to breastfeed should be given support to do so also in our part of the world?
Yeah, so I mean, I can't personally make recommendations, but I can look at the guidelines that exist now. And when you look at the British HIV Association guidelines, when you look at the Swiss guidelines, the Australian guidelines, I think as well, all say that we do not recommend breastfeeding, but if a woman chooses to do so, if she is aware of the risks, then she should be supported to do so. And I strongly believe that that is the case. It may be that in Norway, you will want to, you're doing a study now, so it may be that you will not make that sort of decision until you have the results of that study, because it is important that what is recommended is supported by data. And the data that support the current recommendations to support women are data that come from sub-Saharan Africa, and it may be that actually in Norway they may decide that they want to get local data. But I guess the reason that this is relevant is that in Europe the majority of women living with HIV come from sub-Saharan Africa, so they see their relatives in sub-Saharan Africa successfully breastfeeding, and they don't know why they can't. And I think as healthcare providers, what's really important, certainly to me, is that my patients trust me enough to tell me that they are concerned. And what I don't want is to create a situation where I say, you must not breastfeed, but a woman feels so much pressure to breastfeed that she breastfeeds behind my back, and she doesn't tell me that she's breastfeeding, and I can't support her. I can't encourage her to do her viral load maybe more frequently. I can't stress adherence as much as I would like to. So overall, what I want, what I really hope for with my patients is that they trust me enough to tell me what they want to do. And then my responsibility, I think, is to try to support them in a way that is as safe as possible. And this is just my personal opinion as a physician.
Okay, thank you. We also have a practical question. Is it possible to get the presentation sent out after the meeting?
Personally, I'm happy. I will have to ask my ViiV colleagues, but if they are happy for me to do that, then I will send it to you, Bente, and then you can distribute it.
Great, thank you. It's also a question here. I'll just read it for you. I'm in my menopause now, and my age is 47. Are there some consideration I should be aware of? I do not take any hormones.
Okay, so I cannot give you specific medical advice for your situation, but so I will just speak generally about a 47-year-old woman who is experiencing menopause. So the reason that women experience menopause, so the issue about experiencing menopause is your periods have stopped. So a woman is said to be menopausal when she has had no period for a year. And some women who have menopause don't have any symptoms. Their periods stop and they are fine. And when you look at the guidelines for using hormone replacement therapy, the main reasons for using hormone replacement therapy are for women who have symptoms. So to stop symptoms, hot flushes and night sweats, and also to protect against osteoporosis. That's where the data comes from. And so women who have severe symptoms may choose to, one of the things that women with severe symptoms may choose to do is to take hormone replacement therapy. And women living with HIV can take hormone replacement therapy if they would like to. One has to look at their antiretrovirals to make sure that there are no interactions, but it is absolutely safe as far as we know for women to take hormone replacement therapy, and they may take hormone replacement therapy for as long as they need to. And we know from lots of data that as long as a woman starts hormone replacement therapy within 10 years of her period stopping, that it is safe for the majority of people. But it's something that you should have a discussion with your gynecologist about specifically.
A follow-up comment on that is that the period has stopped for about 2 years ago.
So it doesn't matter when the period stopped, as long as if a woman is having symptoms, it doesn't matter, as long as it's within 10 years of menopause.
Okay. Let's see here.
Actually, one thing I will also say, sorry, just to go on, is that so it's not, if a woman chooses not to have hormone therapy, that's also okay. Many women choose not to, and that's fine. I mean, what's really important, I think, when women start to become menopausal is about trying to maintain their health as best they can, because we know that as women get older, when they lose estrogen and they lose muscle mass, and they also become, and they also develop a risk of osteoporosis. And what we want to do is to prevent what's called frailty. So we want to stop people from becoming, I mean, you know what frailty is when you're weak and you're not strong. And we know that frailty is a problem with people living with HIV, regardless of being whether they're male or female. So, you may see a 70-year-old. You may see two 70-year-olds and they're completely different. One looks really old and the other looks quite young. And the really old one maybe can't look after themselves very well. They need help to do their activities during the day. And the young one goes for a run every day. And what we are now looking at very much in the treatment, in the care of people living with HIV, is ways to prevent frailty, ways to keep people strong so that they go into old age healthy and strong and not at risk of the diseases of aging. And so what's really important for women as they get into the menopause is that they are very careful about what they eat, that they exercise properly, that they don't smoke, that they try to limit the amount of alcohol they drink so that they can remain as healthy as they can into old age. And that you can do with or without hormone replacement therapy.
One comment is also that the problem behind the lack of research on women in Norway is that women make up a small portion of the people living with AIDS in Norway. That is why they prioritize the MSM, they say.
Yeah, okay, so can I be very provocative and say that is not a good reason?
Yes.
And so as women, I think that if you know that there are studies being done in your clinics, then you must and you want to participate in those studies, you must raise your hand and say, yes, you can recruit MSM if you want, but you also have to recruit women. Because if they don't recruit women, we will never have data that shows what the outcomes of those treatments are in women. So the ball is in your court. You have the power.
And also one question here is that EATG is doing a mental health mapping review, which I'm involved in. We found that depression is more common in people living with HIV. For mothers, could postpartum depression be a reason for us to follow up? And what kind of mental health interventions are there for women in the postpartum period?
That is such a good question. And I think the answer is almost certainly yes. So women living with HIV get postpartum depression. So there is no reason that women who don't have HIV get postpartum depression. So there's no reason that women living with HIV should not. And we know that the mental health of women living with HIV is much worse than the mental health of women who don't have HIV. So putting postpartum depression on top of that will really make women struggle. And I'm sure that is almost certainly a reason for loss to follow-up. But I think a woman doesn't even have to have postpartum depression to be lost to follow-up. I think the stresses of being able to look after a young baby are really difficult. And so I think women do need support in the postpartum period, both if they have HIV, but also if they don't. And unfortunately, I think that there are not many interventions for women living with HIV in the postpartum period. That doesn't mean that there are not any, but I'm not really aware of any. But I think that this is, the work that you are doing with the ATG should really inform, I hope, interventions that can be performed for women in the postpartum period, because it's really difficult. I mean, this is one of the most difficult periods of a woman's life, and it has severe implications for her long-term health if she is lost to follow-up in the postpartum period, and her viral load becomes unwell, both for herself and for her baby, because how does an ill woman look after her baby properly? So this is such a good question, and I thank you for it.
Thank you. And there's another one here. If I'm not wrong, you said that a pregnant woman after 6 months has more risks of HIV. Why is that?
If she's okay. So the increasing risk of catching HIV over the course of pregnancy is because of the changes in the environment caused by the pregnancy hormones. So the pregnancy hormones change a lot of the cell makeup of the reproductive tract. They make it easier for HIV to get into the cells, and these changes occur during pregnancy, but they continue after pregnancy, because it takes a while for the hormones to go back to normal. So it's generally because of the changes in the hormones that occur in pregnancy.
And what about women who have to remove their uterus and/or fallopian tubes?
Mm-hmm.
Do they take steroids or estrogen? And how is this with HIV medication?
Good
and how
question.
is also the relationship between osteoporosis and hormones?
Okay, very nice questions. So, when a woman becomes menopausal, she loses two of her female hormones. One called estrogen and the other called progesterone. Estrogen, the loss of estrogen is the cause of the symptoms that women when women have menopause symptoms, it's because of the loss of estrogen. Losing progesterone doesn't usually really cause symptoms. But the reason that we talk about both of those hormones is that if you give a woman hormone replacement therapy with estrogen to stop her symptoms, estrogen, if you give it by itself, causes the lining of the womb to become very thick. And with this thickening of the lining of the womb comes an increased risk of cancer of the womb. It is not necessarily a very high risk, but it is a risk. And so we give this other hormone, progesterone, which the ovaries also produce, but which is also lost during the menopause. We give women hormone replacement therapy with estrogen and progesterone, but the progesterone is to protect the womb, to stop the risk of developing cancer. So you remember when you have a normal menstrual cycle, what happens is over the course of the menstrual cycle, the lining of the womb builds up to prepare for a baby. And then if a woman doesn't conceive, then the lining of the womb is shed. And so what progesterone does is it stops the lining of the womb from continuing to build up and then cause a problem for women later. If a woman has had her womb removed, so if she's had a hysterectomy, then you don't have to worry about that. And so a woman can have estrogen by itself. She doesn't need to have progesterone. And the question about hormones and osteoporosis. So one of the most important chemicals that the body produces that keep the bones strong in women is the hormone estrogen. And the reason that women after the menopause are more likely to develop osteoporosis is because they lose their estrogen. And so estrogen prevents the development of osteoporosis, and that is one of the benefits of taking hormone replacement therapy. So if a woman takes hormone replacement therapy because she has hot flushes, for example, she will also be doing something to protect her bones. There are other ways to protect the bones, and there are other ways to treat osteoporosis. But the sort of body's natural way to prevent osteoporosis is by the production of this hormone called estrogen, which can be replaced after the menopause by giving it artificially. So most of the recommendations for how estrogen should be given is that it should be given through the skin in a way that is called transdermally rather than by mouth. And because one of the risks of estrogen, and some people who know about the oral contraceptive will know that there is a small risk if you take the oral contraceptive of a blood clot in the leg or in the lung. But if you take estrogen transdermally through the skin, as would be the case with hormone replacement therapy, there is no risk of that. And so I recommend when my women patients are taking hormone replacement therapy that they take it through the skin and not so as a gel or a patch and not by mouth. And then I also look to see what antiretrovirals they're taking. And if they're taking antiretrovirals that do not interact with estrogen, that do not cause the levels of estrogen to be low, then they can continue on their current antiretroviral regimen. But if they're on a regimen that looks like it might interact, if they are not my patient, I will talk to the HIV physician who is looking after them. I'll talk to them as well and suggest that it might be possible to switch to something else. Sometimes it is not possible if there is a lot of resistance or if somebody does not tolerate an antiretroviral. But with the newer antiretrovirals that are available now, many of them do not have the same interactions that older antiretrovirals had. And so it is often possible to switch to enable a woman to have hormone replacement therapy.
Thank you. We have received another question here. How should women living with HIV take care of themselves and their health as they approach menopause, and what should they be aware of?
Thank you. This is a nice question. So what I will say is that I don't think that women living with HIV need to take care of themselves in any to a woman in the general population. And what is really good now, this is the case in the UK, I don't know whether it's the case in Norway, but everybody is now very, very concerned about their health. People are trying to live healthily, everybody's exercising. All my friends have this Peloton bike, which is very expensive, and I'm not going to buy one. I prefer to go for a walk. But everybody is really obsessed with doing exercise, which is a very good thing. And also interested in watching their diet. And this is what should also be the case in women living with HIV as they approach menopause. Because what you want to do is to try to reduce the risk of developing heart disease. So being very careful about your diet, and the advice that is generally given is to follow this so-called Mediterranean diet. And by that I mean having a diet that is rich in fruit and vegetables, particularly vegetables like tomatoes and green vegetables, using olive oil rather than other types of oil, not avoiding alcohol completely, but being very careful about how much alcohol you drink, and exercising. Exercising because we know that people gain weight as they get older. But one thing that women who are menopausal also notice is that the shapes of their bodies change. So many women, even if they're slim elsewhere, start to gain weight around their tummy. And this gaining of weight around the tummy is associated with an increased risk of heart disease. So this is something that may be associated with what I talked about before, called the metabolic syndrome. So trying to avoid gaining weight as one gets older is really important. I personally don't think that women living with HIV need to do anything special. I think that they should just follow the advice that is given to women in the general population about keeping themselves healthy. And the most important thing a woman can do is to continue to take her antiretroviral therapy and to take it properly. And if you're having problems with your antiretroviral therapy, to speak to your doctor about it, so that so that the issues that you have with your treatment can be addressed, so that, because we know that people who struggle with their treatment don't take it properly, and then that may lead to problems in the future.
Thank you. Don't have any more questions here. Maybe someone is writing in the chat. Let's wait for her.
Okay.
To say. Let's see here. How frequently should women living with HIV take a cervical smear?
Okay, thank you. So this depends very much on the country where you live. So the guidelines in different countries are different, but many guidelines say that women living with HIV should have smears more frequently than women in the general population. What we don't know is whether this is still the case with antiretroviral therapy that is very effective, and so we have a situation now where women are not as immunosuppressed as they used to be. And there is some research looking into this to see whether actually women living with HIV do need to have cervical smears as frequently as women without HIV, particularly because in some countries, and I don't know if this is the case in Norway, cervical smear testing is also done with testing for this virus called HPV. So this virus HPV is the most common cause of cervical cancer. And women living with HIV have higher rates of HPV than women without HIV. And so if you were to do a cervical smear and test for HPV and not find it, is it then okay for women living with HIV to have cervical smears at the same frequency as women who don't have HIV? So we don't know the answer to this, but there are now starting to be studies to see whether this is the case. So for the moment, my advice is to follow the guidelines in the country where you live.
Thank you. There's another one writing here, so we just give her a few seconds. Let's see. I will just say thank you.
Oh, it's a pleasure. Oh, thank you, and thank you for having me. No, the questions have been really good, and thank you.
One more question is coming here. We really do appreciate it. The knowledge on women living with HIV is much poorer than on men, as you said. So this has been something that our women have asked for a very long time. So.
Well, it's my pleasure.
I have another one here. Why are there few studies on women taking into account that over 50% of the population, people living with HIV, actually is women?
It's a very good question. And I think the answer is complicated, but I think it's complicated and it's simple. I think that the reason is that people think it's too difficult. I think people make assumptions that women don't want to participate in clinical trials, so they don't ask them. I think that there are understandable and justifiable worries about what happens if a woman becomes pregnant on a treatment if we don't know that it's safe. And this is a completely valid worry, but it is a worry that then stops us from moving forward. And so when you think about how a drug is developed, first of all, it is tested in animals, and some people have problems with animal testing, and that is one issue that I won't go into. But what is done is that drugs are tested in animals, and they're tested in the babies, in pregnant animals, for example. And then if there are no abnormalities seen in the babies of these pregnant animals, then they go on to do further testing, and eventually they then start to test in human beings. If they find, when they do tests in animals, that the babies of these animals, the babies of these animals who are given the drug have a problem, then they may not go on to. Then they may go on to say, well, we will not test this drug in pregnant women because there is a signal in animals. But where there is not a signal in animals, then it would be reasonable to consider when you start to do testing in human beings, to think about how you can recruit women into trials, but to do it as safely as possible. And one way that one might start doing this is to, when a woman becomes pregnant in a clinical trial, not to force her to stop, not to force her to leave the trial, but to say, okay, we will continue to follow you to see what happens. A woman will have to agree to this, and it's possible that the outcome may not be a good outcome, but the thing is that at least we will know. And if we know, we can say, we absolutely know that this treatment is not good in pregnancy. At the moment, we do not know. So when a woman is given a treatment, or when a woman is started on a treatment and then switched to something else, if she were to say, this new treatment that you're switching me to, has it been tested in pregnancy? For most drugs, we would say no. So how can we then reassure a woman that it's safe, that whatever we are giving her is safe if we haven't tested it? And that's why it's really important to think about how we can test, so how we can give pregnant women treatments in clinical trials so that we know for certain whether a drug is safe or not. Because what this means is that some people will say, well, actually, we're never going to use this drug in women because we have not tested it. And it may be the best drug that's available, but women are denied this because nobody has tested it. Or you have a situation where we say, well, we'll give it to women, but we don't know whether it will cause a problem. So both ways, women end up having a raw deal, as they say. Women end up being disadvantaged.
Okay, thank you. Should women with HIV take the HPV vaccine? And at what age? Is it possible to take it also when you are elderly, like 40 or 50 or, yeah?
I wouldn't call 40 elderly. What am I? This is a good question. And the guidelines, again, are very different from one country to another. I think that the license for the HPV vaccine, as far as I know, is for young women up to the age of 26. But I also know that in many countries, certainly in the UK, because rates of HPV are very high in men who have sex with men, HPV vaccine is being given to men up to the age of 45. It's not being given to women routinely. And the argument for that apparently is because rates of, so it's given to men who have sex with men because HPV causes very high rates of anal cancer. But we know that HPV causes high rates of cervical cancer. I think, and I'm not absolutely certain, that one of the reasons it's not given to women in the UK is because they have done cost effectiveness analyses. And you know, in the UK, I think, as is the case in Norway, maybe we have a public health system, and so in order to provide treatments for free, they test whether they're cost effective. And it may be that it was decided that it wasn't cost effective to give the HPV vaccine to women. But I do know that in some countries, women are able to have the HPV vaccine, particularly, I think, in countries where there is private medicine and insurance companies will pay for it. There is some question about whether the HPV vaccine will work as well in older people as in younger people, because there are many hundreds of HPV viruses. And when you're very young, you will not have been exposed to those viruses, especially if you're not sexually active. But as you get older and as you are more sexually active, then you may be exposed to more viruses. And so you may have already caught the HPV vaccine by the time you're offered a vaccination. Sorry, you might have already caught the HPV virus before you're actually offered the vaccination. And there's a question about whether the vaccine will work as well in people who already have caught the virus. But not everybody catches every HPV virus, and so it's possible that for some people the vaccine will still work if they haven't caught the strain of virus that vaccine covers. So the HPV vaccine doesn't cover all the HPV viruses. It covers the viruses that may cause some. Well, it covers some of the viruses that may cause cervical cancer. But yes, it depends on the country. And I don't know what the situation is in Norway. Oh, I see a note that says it's coming in Norway. So there.
Yeah, the HIV treatment injection is coming. And what are your thoughts about that? Do you have some?
I think I'm not allowed to talk about that.
Sure. Sure.
Sorry.
Also, some of the response after your talk is that I would be glad to participate in clinical trials.
Oh, good. Very good. I'm really glad to hear that. Yeah, so I think maybe the next time you go to your clinic, you might say, are there any trials? And they may not necessarily even be treatment trials. There are lots of trials. So just to say, and often what my patients will say to me, if there isn't a trial going on at the moment, they will say, well, if there's nothing at the moment, can you please tell me when there are clinical trials? And then they'll just put your name down so that when a trial comes up, they will know that you might be interested. And as I said, there is no obligation to participate, but I think it's at least being able to know about it, to hear about it, to have your questions answered, and then to decide whether this is something that you think would be good for you.
Thank you. I don't see any more questions, nor in the chat or in our phones. So I would like to use the opportunity to thank you so much. I really appreciate this, and we'll also send out your presentation if you get it approved. So we're looking forward to that. So thank you everyone for all the questions you also given to Dr. Nieka. Thank you.
Well, thank you for inviting me, Bente. It's been a real pleasure, and thank you for your questions. They're all really important questions, and I hope that I answered them to your satisfaction, and I hope maybe to be able to speak to you another time. Thank you very much, and have a good evening.
Thank you too.
Bye-bye.